Bladder cancer, part of the world, have been looked at in different ways. Is it coming up? And the one thing we haven't done a good service is in terms of research in our part of the world. If you go through PubMed looking for research on bladder cancer in our part of the world, you find about 50 papers in the last 50 years. So our part of the world hasn't really looked at bladder cancer in a big way. But when you look at the literature, you see the reason why. The reason being that bladder cancer is not a very common disease in our part of the world. In the United States of America, next slide, in the United States of America, it is the fourth leading cause of cancer. But in our part of the world, bladder cancer is not common except in Egypt, where it is a very common disease. There are very wide variations in the incidence and mortality from bladder cancer, and the highest incidence having been seen in males and females in Europe and North America. And when you look at global scan, again, you find Egypt, because of the Nile, we are told, it has a very high incidence of bladder cancer. The lowest incidence of bladder cancer is in Asia and Sub-Saharan Africa. And studies done here have shown it to be about 1 to 2% at the very most in most of East Africa and Middle Africa. Mortality is highest in parts of Europe and North Africa, the Tunisians, the Moroccos. In Asia and Central America and the Middle Africa, it's very low. The only thing that is universal in the world is the change in mortality and incidence figures that have come with change in smoking patterns. When you go to an Egyptian, I hope there are no Egyptians today, if they are there. When you go to an Egyptian airport, the one thing that strikes you is the smell of cigarette in the airport. And I think that is reflected by the very high incidence of bladder cancer. So in Kenya, Kenyans and the others, papers showed low incidences of bladder cancer being less than 2% of the cancers. The noticeable change from the studies of Ndagwada in the early 90s and Kenyans in the mid 80s was the change from high incidence of squamous cell carcinoma during the time when Ndagwada did his study to transitional cell carcinoma by the time Kenya was doing the study. Again, perhaps reflecting, and I think Kenya did comment about that, the changing attitudes towards smoking by Kenyans. In the developed world, the majority of patients have transitional cell carcinoma, with adenocarcinoma being about adenocarcinoma and squamous cell carcinomas and others being 10%. And I think this is the reason why the treatment of bladder cancer did not develop very well in our part of the world. The majority of patients are not very well treated when they present with the bladder cancer. Look at a country like Malawi, presented last year. They had the biggest commonest tumor was cancer of the esophagus, followed by breast. Bladder was number 3 there, and the rest of it. So in Malawi, if you're looking at the number of patients who have the bladder cancer, is probably common, maybe a reflection of smoking there. And that's the same study. Then there's a study by the Egyptians that looked at other environmental exposures, which showed that exposure to schistosomiasis increased risk of bladder cancer amongst Europeans. In Morocco, bladder and colorectal cancers are again common. So the variation of bladder cancer in the whole region is very wide. The smoking becoming a major issue in Tunisia. We know in in Egypt, it is schistosomiasis and smoking. And again, Egypt long time ago was having more squamous cell carcinoma. Recently has changed, well, not changing their number of tumors, they have changed to transitional cell carcinoma, probably because of what you find when you go to the airport. And so it is the common leading cause of bladder cancer. It is the leading cause of cancer in men. But there has been a decline in squamous cell carcinoma. Like, is that me? Attributed to schistosomiasis change. And so when you look at the part of that study that is missing, the one that I said, I think you didn't capture everything. The one thing we looked at the bladder cancer in Kenya and what has been done in this part of the world. I went through the records in the last 1 year, and what surprised me is that we had 10 cases of bladder cancer in the whole of Kenyatta National Hospital in a full year. And it's not that these patients don't come, but the reason being that when they come to our hospital, when they present with hematuria, they do not go to the surgical clinics. From the surgical clinics, the patients go to the radiotherapy unit, and they're given radiotherapy. So in our part of the world, the management of bladder cancer is not optimal at all. Hardly any cystoscopies are done for our patients in the Kenyatta National Hospital. Hardly any TRBTs. There were 3 TRBTs done in the whole hospital in the whole of 1 year for newly diagnosed bladder cancers. There was a difference, however, in the private sector. In the private sector, we had, on my own, 15 patients who presented with hematuria, and they were all TCCs, and they were all superficial bladder cancers. In the Kenyatta National Hospital, no case of cystectomy was done. And I would like to ask any of the audience, the urologists in this region, how many of you have done a cystectomy in the last 1 year? Raise your hands. It's only 2 cystectomies in the whole of 1 year. Perhaps bladder cancer is very low, but there is a problem in the way we are dealing with our cancers. So and then by a show of hands, how many people have done more than 5 TRBTs in the last 1 year? More than 5 TRBTs in the last 1 year. Again, it is half the audience. So that means that our bladder cancers are being treated by other people other than the urologists. And we will need to change how bladder cancer is managed. Our diagnosis of hematuria, our diagnosis, the patients who present to us with hematuria are treated with antibiotics forever until they present with disease that we can neither resect and for which we cannot do cystectomy. So our experience with TRBT is not as good as other parts of the world. Our experience with cystectomies is not as good as in other parts of the world, and majority of our patients who have cystectomies do not have extremely good results. I looked at my series and found that in the last 10 years, I've done only 10 cystectomies. So I'm not an expert in doing cystectomies. And perhaps being in the biggest institution in Kenya that sees bladder cancer, perhaps that reflects what is happening to our patients. Our patients, the index of suspicion for bladder cancer in our part of the world is very low. And that is perhaps why we need urology departments all over the country to start looking for bladder cancer, to start treating bladder cancers, starting from simple cystoscopies, TRBTs, to actually being able to do cystectomy. A bit of my slides, I think, disappeared on the I did, but that was the message, that bladder cancer in our part of the world is a low incidence disease, it's underdiagnosed and undertreated, and we need to look afresh and probably start having a registry on bladder cancer. Thank you.
Possibly when I start myself is that the experience of the approach to treating the patient in Baturi, where I practice is that almost invariably from the physician, they treat as infection. The suspicion is actually very low, And when they find that the patient actually is not improving, that is months down the line, if not a year. So that's a challenge, and I think the answer to that problem does not entirely rely on the neurologist, because I think everybody needs to be sensitive about the referral to the neurologist in time. Yes, Najib.
I think the important thing is to stress on the importance of one-stop hematuria clinics, where the patient has imaging with a CT, urogram, or IVP and cystoscopy, preferably on the same day, so that a diagnosis can be made. And that way you'll be able to pick more of these tumors.
Thank you. Bladder.
Thank you, Chair. I think I was going to say what Dr. Naji has said.
Okay.
But the only thing that I wanted to add is that we are the people who are holding the mantle. Maybe we have not disseminated this information well enough. The physicians should be told that anytime they say, whether it is microscopic or macroscopic, they should refer these patients to the urologist, rather than sticking with those patients.
Thank you. Somebody.
Thank you, Mr. Chairman. Just to enlighten me, the incidence of adenocarcinoma that we used to see with schistosomiasis, what is the... Yeah. Is that going low in the appropriate areas?
Yes, when you look at KNH, the number of squamous cell carcinomas that you see is very low. The adenocarcinomas are congenital diseases for patients with the adenocarcinomas is for patients who have had nucleus elements in the bladder. But for squamous cell carcinoma, the partial cystectomies that my teachers used to do are not there anymore. I don't know. I don't know anybody who has seen a big squamous cell carcinoma in the last 5 years. We don't. So the change in schistosomiasis, the treatment of schistosomes in our part of the country has taken away schistosomiasis and squamous cell carcinoma. TCC is rising, but we are missing it because we have not sensitized the doctors that refer to us. In terms of what Naji has talked about, a hematuria clinic with all those things, with a CT scan, good thinking. I don't know what the people in India do. I don't know whether they have those one-stop hematuria clinics, because I do not think that Kenya can afford those one-stop hematuria clinics by the look of things at the moment.
Thank you.